Good afternoon. On behalf of the European Atherosclerosis Society, I would like to extend a warm welcome to all of you. I'm Lale Tokyozolu from Hacettepe University, the past president of the European Atherosclerosis Society. Our topic today is Women, Dyslipidemia and Atherosclerosis, which we will be exploring with top experts from the field. I'm delighted to be seeing your messages from all over the world, so I would like to greet all my friends whom I haven't been able to see for a while face to face. Atherosclerotic vascular disease is the leading cause of mortality in women, especially in middle-income countries, according to the most recent statistics of the European Society of Cardiology. With the increase in diabetes and obesity, women are getting the disease much younger, and although the biology of the disease is the same in both genders, the weight of risk factors may differ, and gender-specific risk factors alter the course of the disease in women. Despite some improvements in recent years, underdiagnosis and undertreatment is still a major problem. Ischemia without obstructive coronary artery disease is increasingly seen in women and is not a benign condition as thought to be in the past. So we will be discussing these issues with our distinguished faculty, and we'll be taking all your questions in the very end. So as soon as you have a question, please write it in the chat function. Dr. Janine Routers van Lennep from Erasmus Medical Center will kick off by talking about dyslipidemia in women. This will be followed by Dr. Erin Mikos, who is the Director of Women's Cardiovascular Health in Johns Hopkins, and she'll be talking about atherosclerotic vascular disease in women. And finally, Dr. Fabrice Bonnet from University of Rennes will be talking about why are diabetic women not protected against atherosclerotic vascular disease. So Janine, the floor is yours now. Without further ado, I'd like to invite you to give your lecture.
Welcome to this webinar. My name is Janine Routers van Lennep. I'm an associate professor in the Erasmus Medical Center, Rotterdam, the Netherlands. Today I will talk about dyslipidemia in women. Maybe you wonder why dyslipidemia in women? Why is it an issue? Because if you see a lipoprotein, you cannot tell if it's male or if it's female. Well, maybe that's even literally the case. On the other hand, women and men do have different lipoprotein particle sizes. Women have a more favorable lipid profile regarding LDL and HDL subclasses, but that's not what I'm going to discuss today. Today I will discuss female-specific aspects of dyslipidemia, being menstrual cycle, pregnancy, menopause, and also some differences in treatment between men and women in dyslipidemia. Well, first of all, every woman knows that the menstrual cycle has an enormous influence on a female body. However, the influence of the menstrual cycle on lipids is not taken into account in clinical practice. Interestingly enough, the effect of the menstrual cycle on lipid levels has been studied since the 1970s in more than 40 studies, and I know because together with my colleague Kirsten Halven, we are performing a meta-analysis on this subject. In general, studies that study the lipid levels show that these are higher in the first half of the menstrual cycle. That's the follicular phase, when estrogen and progesterone levels are low. And then lipid levels decrease in the luteal phase. That's the second half of the menstrual cycle, when hormone levels increase. This is an example of the largest study consisting of 256 healthy women who are mean age about 27 years old and who had 8 visits during 2 cycles. And although the variation in lipid levels is modest, 17.7% of the women had an LDL above 3.5 anywhere in the cycle, but only 10% had a consistently LDL level that was higher than 3.5. Moreover, importantly, these women had normal to low LDL-C levels, and it's reasonably to assume that the absolute difference in LDL-C levels is higher in women with high lipid levels, such as the case in FH. Currently, we are studying this, and maybe in the future we will ask women to time their lipid measurements according to their menstrual cycle. In pregnancy, lipid levels increase during the course of pregnancy. Triglycerides increase about 200% and LDL levels about 130%. In women with normal cholesterol levels, this absolute increase is from 3 to 3.9 millimoles per liter, so that's less than 1 millimole. But in women with FH, the increase in LDL-C is almost 2 millimoles per liter, so the absolute increase is far larger. Regarding lipid-lowering medication in pregnancy, these are the recommendations. Stop statins and ezetimibe at least 1 month before conception and PCSK9 inhibitors 3 months before conception. This is taken into account the half-life of the medication. These medications cannot be used during pregnancy and also not during lactation. The only medication that does not cross the placenta are resins, such as cholestyramine and cholesevelam, and these are considered safe. However, the evidence about tolerability and lipid-lowering potential in pregnancy is very scarce. Both the EMA and the FDA have contraindicated the use of statins in pregnancy, as statins are considered as potential teratogenic and that the risks clearly outweigh any benefit according to the FDA and the EMA. However, although clear early case series reported congenital anomalies, which were not specific, more recent observational studies did not report an increased risk of congenital anomalies with statin exposure in pregnancy when compared to a control group, and the prevalence of congenital anomalies was similar to the general population. Therefore, statins are probably not teratogenic. Until more information is available, statins still should be avoided in pregnancy. Regarding breastfeeding, rosuvastatin appears to pass preferentially into breast milk. Most data show that the estimate infant exposure is very low, although it has to be said that there's very scarce data. So until more data is available, also statins are contraindicated in breastfeeding. Important for counseling women with FH is that women with FH who have a wish to conceive do not have an increased risk during pregnancy of pregnancy complications such as premature delivery, a low birth weight baby, congenital malformations, or hypertensive disorders of pregnancy such as preeclampsia or HELP syndrome. And interestingly is that although it seems that women with FH do not have an increased risk of developing myocardial infarction during pregnancy, this has never formally been studied. Also important for counseling is that in some countries, like in the Netherlands, it is possible to test the FH mutation if this mutation is known in the FH parent. And this can be tested in cord blood. And even though this will not have consequences for treatment of the child until he or she is 8 to 10 years old, my experience is that most parents do like to know if their child has FH or not, as 50% of the children will not have FH, and this is also a relief for the parents. Lastly, hypothetically, children who are born from a mother with FH and who are developed in utero in a high cholesterol environment could have long-term imprinting and higher cholesterol levels compared to children who inherited FH from their father. We studied this in a Norwegian and Dutch FH children's cohort, and we found that this was not the case, as lipid levels were similar in children with FH who inherited FH from their mother compared to their father. In the general population, women develop CVD events 10 years later than men. However, in FH women, they experience CVD at a similar age compared to men. Therefore, it seems that they lose their natural female protection. Maybe this might be partly because the last statin years related to pregnancy. This is what we do not know for sure, because it might also be differences in treatment, which I will discuss later. A study of more than 1,000 women during menopausal transition showed that total cholesterol, but also LDL cholesterol and ApoB, showed significant increases and HDL-C a decrease within a year of the final menstrual period. Interestingly, no evidence of final menstrual period was found on blood pressure, insulin, glucose, or Lp(a) levels, and also not on hemostatic and inflammatory factors. In clinical practice, it is very important to record menopause in female patients who are treated for dyslipidemia, as increased lipid levels might necessitate dose adjustments for lipid-lowering medication. Not all women will spontaneously mention their menopausal transition. Many previous studies showed that women are treated less often with statins and also with less potent statins. I will discuss one of the more recent papers. This is a registry and a survey among more than 5,600 participants. 43% were women eligible for statin treatment according to the 2013 American Heart Association cholesterol guidelines. And this study showed that women were less likely than men to be prescribed any statin therapy, 67% versus 78%, or at the guideline recommended intensity, 36% versus 45% in men. Interesting about this study is that they also assessed the reason why women were not using statin therapy. And what they found was that women were offered less often statin therapy, while they also declined and discontinued treatment more frequently. However, the largest effect for accounting for women not using statins was that they were not offered a statin. When surveyed, it was found that women were less likely to believe statins were safe or effective compared to men, and similarly, women were more likely to experience perceived statin-associated side effects and discontinue therapy because of the side effects than men. Male patients, both among those patients previously on the statin and among statin-naive patients, were more willing to try a statin. Because it appears that both the healthcare professional and the patient contribute to the factors, to the sex-related differences in statin use, addressing these differences will likely require a multifaceted approach. So to take home, women with dyslipidemia are special because they have a menstrual cycle, which you might take into account possibly later if we have more evidence. Also, women can become pregnant, and that involves timely counseling. That might also affect their long-term cardiovascular disease risk. And also they experience menopause, which can increase their lipid levels. And very important is that we treat women with dyslipidemia well. Thank you for watching.
Hi, I'm Dr. Erin Mikos. I'm the Director of Women's Cardiovascular Health at Johns Hopkins University in Baltimore, Maryland. And I want to thank the European Atherosclerosis Society for having me part of their webinar to talk about atherosclerotic cardiovascular disease in women. I have no disclosures. So this represents United States data, but it's likely similar to developed countries around the world. We see in the 80s and 90s that cardiovascular disease mortality started to decline in men, but it actually was increasing in women till around 1999 when the launch of the first women-specific prevention guidelines and the Go Red for Women campaign. And then we saw a steep decline in cardiovascular disease mortality in women. Nevertheless, for many years, more women died each year of cardiovascular disease than men. Till about 2013, when CVD mortality in women dipped slightly below men. But for both men and women, if you look at what's happening at the right end of this curve, we see a plateauing and even an uptick due to the epidemics of obesity and cardiometabolic diseases. In fact, heart disease mortality for middle-aged women is on the rise, has increased 7% since 2017. And this is one of my studies looking at premature mortality in women under the age of 65 in the United States. Now, in this younger age group, cancer is the leading cause of death in women. And we see over this 30-year period from 1999 to 2019 that fortunately cancer mortality was declining. On the other hand, since 2010, heart disease mortality has increased, such as that narrows the gap between heart disease and cancer mortality. And if these trends are not overturned, heart disease is set to overtake cancer as a leading cause of death in younger women too. Now, the American Heart Association has sent out surveys over the years assessing women's awareness of heart disease as a leading cause of death. And in 2009, 65% of women were aware that heart disease was the leading cause of death. But this awareness declined to only 44% in 2019. And this lack of awareness was particularly noted among Hispanic and Black women, and also among younger women, of whom primordial prevention would be likely the most effective. Now, men and women share many risk factors in common, but there can be disparities conferred by the risk of traditional risk factors. For example, diabetes confers a greater relative risk in women than in men. And similarly, smoking is associated with a greater relative risk of a myocardial infarction in women compared to men, particularly in younger age groups. Now, with blood pressure, hypertension is more common in older women, and some might think that hypertension accelerates after menopause. But rather, women are on a steeper trajectory in blood pressure rise their whole lifespan, such that the average blood pressure in women starts out earlier in life lower than men, but they're on a steeper rise so that the average blood pressure in women overtakes men at older ages. And this sets the stage for cardiovascular disease that not only occurs later in life in women, but also differently. Additionally, there are unique risk factors that women experience throughout their lifespan that men do not, related to pregnancy, hormones, menopause. We know that adverse pregnancy outcomes is associated with increased maternal risk. What is the chicken versus the egg? Well, it may have been that these women weren't completely healthy before pregnancy. Maybe they had subclinical glucose intolerance, obesity, elevated blood pressure, dyslipidemia, and then they became pregnant as nature's free stress test, and these became clinically manifest. Or it may be that these adverse pregnancy outcomes increased maternal cardiovascular risk in a causal fashion, that perhaps the thrombotic and inflammatory milieu of preeclampsia causes endothelial dysfunction that increases a woman's risk for cardiovascular disease later in life. Now, I had the pleasure of being a co-author on the 2019 American College of Cardiology, American Heart Association Primary Prevention Guidelines. And we emphasize that the most important way to prevent ASCVD is to follow a healthy lifestyle throughout the lifespan. And additionally, we highlighted these ABCDEs of prevention for a multifaceted, multi-pronged approach. Now, after lifestyle, when we start thinking about pharmacotherapy, we recommended in our US guidelines that those aged 40 to 75 that we start with a 10-year risk assessment using the pooled cohort equations. Women who are low risk, less than 5% 10-year risk, often lifestyle modifications enough. High-risk women with more than 20% 10-year risk, we're thinking lifestyle and high-intensity statins to lower LDL by 50% or more. And then there's these groups in the middle, the borderline and intermediate risk. We think that a 10-year risk above 7.5% identifies a net benefit threshold for statins as part of a clinician-patient risk discussion. But these groups, we also recommend that clinicians consider risk-enhancing factors. These are clinical factors or laboratory factors that we already know about our patients. And if present, this would favor the decision to initiate statin or intensify statin. Now, I was really pleased in our guidelines that we highlighted these female-specific risk enhancers of premature menopause and preeclampsia. We also mentioned rheumatoid arthritis, lupus, these inflammatory conditions that are more prevalent in women. But our guidelines acknowledge that even after we estimate 10-year risk, and even after we consider those risk-enhancing factors, there can still be uncertainty about the net benefit of statins. And in these cases, we said you could order a coronary artery calcium score with a 2A indication to help refine risk a little better and guide shared decision-making with our patients. I think you're familiar with this test. It's performed by non-contrast CT. It's low radiation, only 1 millisieverts. It's a strong marker of total atherosclerotic plaque burden, and it has emerged as really the superior prognostic marker of risk, likely because it integrates a lifetime of risk from genetics, traditional risk factors, and novel risk factors, such that if coronary artery calcium is present, this would upgrade someone into a higher risk category. On the other hand, a coronary calcium score of 0 is a favorable prognostic marker and can downgrade someone into a lower risk category. And this is based on large epidemiology studies, such as this data from MESA. So on this graph, we're looking at 10-year event rates, ASCVD event rates, stratified by coronary artery calcium score, and the red dotted line depicts the 7.5% 10-year threshold that we think is the net benefit threshold for statins. This very light gray line represents a 0 score, and individuals with a 0 score have a very low event rate over the next 10 years. On the other hand, any non-0 score crosses above the 7.5% threshold over the 10 years in a graded fashion, with the higher the score conferring greater risk. Now, at a given age, women are less likely to have prevalent coronary calcium than men. But when coronary calcium is present, this confers a greater relative risk in women than it does in men. This is data from the Coronary Artery Calcium Consortium looking at CVD mortality. And we can see in this left panel that both men and women with a 0 score over 20 years have a very low rate of CVD mortality, less than 0.6%. On the other hand, any detectable coronary calcium score above 0 is associated with risk. And it's associated with a greater risk in women, a 26% greater relative risk in women than in men. And similarly, we see for coronary calcium scores of 100 or 400 or 2 vessels or 3 vessels, this confers a greater relative risk in women than it does in men. This was another analysis from the Coronary Artery Calcium Consortium focusing on individuals with diabetes. And again, we see a similar thing, that for a given coronary calcium score, this confers a greater relative risk in women than in men, with significant interaction by sex. Now, we usually get coronary artery calcium scores in asymptomatic individuals. But women also have a greater prevalence of angina than men. And in the setting of angina, women are more likely to have non-obstructive coronary artery disease across the age groups. However, ischemia with non-obstructive coronary disease is not benign. It's associated with increased risk of major adverse cardiovascular events. And furthermore, these are not normal coronary arteries. In the WISE trial of women with ischemia and non-obstructive coronary arteries, 80% have atherosclerotic plaque, and risk factors correlated with plaque volume. So it's important that we identify and treat risk factors when present. Now, this is data from the CONFIRM registry. These were patients with a clinically indicated CT angiography. And we see that non-obstructive disease in both men and women is associated with a heightened risk of MACE as well as all-cause mortality. However, high-risk plaque may confer a greater risk of MACE in women than in men. This is data from the PROMISE trial, the CT arm, that high-risk plaque defined as positive remodeling, low CT attenuation, or napkin ring sign confers a greater relative risk in women than in men, and this is even after we adjust for the presence of stenosis. Additionally, this is data from the CONFIRM registry looking at different types of plaques and lesions on coronary CT angiography, and we see generally that this confers greater relative risk in women than in men. Particularly, I want to point your eye to the top bar, non-obstructive left main disease associated with a 78% greater relative risk in women than in men for MACE. So men and women have different types of plaque characteristics. Men tend to have larger arteries, larger lipid core, greater calcification, thicker fibrous cap, higher coronary calcium score, and more obstructive disease, where women tend to have smaller arteries, lower plaque volume, lower calcification, and more ischemia with non-obstructive coronary disease. However, seeing is believing, and many societies are moving towards recommending CTA as the first-line test for evaluation of stable chest pain. This is based on data like the Scott Hart trial that compared among patients with stable chest pain a CTA-guided approach versus standard of care, and showed that the CT-guided approach was associated with a 41% reduction in major adverse cardiovascular events at 5 years. And this was driven by a 40% increased uptake in preventive therapies, aspirin and statins. So if you can see disease and get patients on appropriate anti-atherosclerotic therapy, you can have meaningful reduction in events. In the Scott Hart trial, a CT-guided approach had similar benefit in women and in men. Now, in the PROMISE trial among patients with stable chest pain, compared head-to-head CTA versus stress test. So an abnormal CTA in women defined by obstructive disease was associated with a higher event rate, higher prognostic risk compared to an abnormal stress test in women. On the other hand, an abnormal CTA and an abnormal stress test conferred similar prognostic value in men. So again, many guidelines have recommended moving towards CT angiography as the first-line approach for evaluation of stable angina. And we recommend this as well in this review article, not only because you can identify obstructive disease, but really if you can see non-obstructive disease and get individuals on appropriate medical therapy, this perhaps can prevent future myocardial infarctions and reduce costs. So the statin recommendations for women, so statins are indicated for secondary prevention, for primary hyperlipidemia, LDL above 190, for patients with diabetes, high-risk primary prevention with 10-year risk above 20%, or intermediate risk in the setting of risk enhancers. Generally, statins are not indicated for low-risk women, less than 5% 10-year risk, or in any woman who's planning to get pregnant in the next 1 to 2 months, you would withhold statins during conception, pregnancy, and breastfeeding. Now, statins might be considered also in borderline risk individuals in the setting of risk enhancers as part of a patient-clinician risk discussion. So what about aspirin? Well, there was 3 pivotal trials in 2018 that suggested aspirin primary prevention perhaps did more harm than good. So therefore, the aspirin recommendations for primary prevention in women, again, aspirin is still recommended for secondary prevention, but generally in primary prevention, healthy women with no major risk factors are not indicated for aspirin, and you generally want to avoid using it routinely after the age of 70 or in anybody with prior risk of bleeding. Now, aspirin might be considered primary prevention among individuals who are current smokers, have significant subclinical disease or strong family history, if they are also at low risk for bleeding. So in summary, cardiovascular disease is the major cause of death in women worldwide. Women are underrepresented in clinical trials, and results are often not reported by sex. Women and men share many risk factors in common, but several are unique to women. Atherosclerotic plaque is prevalent and prognostic in women, and coronary microvascular dysfunction may be present if no obstructive lesions are found. Women have a lower burden of plaque at a given age. However, the presence of plaque, as assessed by the coronary artery calcium score, confers an even greater risk in women than in men. Among stable chest pain patients, women benefit from coronary CT angiography due to high normalcy rates and fewer downstream testing. However, the presence of non-obstructive coronary disease is associated with an increased risk of major adverse cardiovascular events, particularly non-obstructive left main. Likely mechanisms are due to plaque erosion and subsequent thrombus formation. So therefore, in ischemia with non-obstructive coronary artery disease, it's important to recognize that atherosclerotic plaque is prevalent and to treat this with statins, low-dose aspirin, ACE or A or B. Essentially, we need to intensify preventive care for all at-risk women. Thank you for your attention. I hope you enjoy the rest of the webinar.
Good afternoon. We are speaking about cardiovascular risk of diabetic women. My links of interest. So, we know that diabetes prevalence is increasing worldwide. The cardiovascular burden of diabetes remains an important question. But what about sex differences among people with diabetes? Firstly, prevalence of diabetes is still higher among men than in women, with some differences across countries. In terms of cardiovascular risk, women without diabetes have a much lower risk of developing CVD as compared to non-diabetic men of the same age. But this advantage disappears once type 2 diabetes is present. This is a French study showing that both prevalence and incidence of type 2 diabetes is higher in men than in women. In France, incidence of treated type 2 diabetes is about 1.8-fold higher in men than in women. And this is in agreement with data from Europe. The large European cohort named Interact EPIC confirm that incidence of type 2 diabetes is higher in men than in women, with an hazard ratio of 1.50 in this study. Now, let's look at the gender differences for cardiovascular outcomes. For myocardial infarction, and this is data from France, incidence is higher in diabetic men as compared to diabetic women. But for stroke, the incidence in women is close to that in diabetic men. You may note that the incidence of stroke in France is higher than that for myocardial infarction. This very recent French study is based on a sample of nearly 3 million individuals who were hospitalized. The follow-up was of at least 5 years, and cardiovascular outcomes include cardiovascular death, myocardial infarction, stroke, and heart failure. The results confirm that absolute risk of CVD is greater in men than in women in presence of diabetes, and absolute risk of CVD is greater for diabetic people as compared to non-diabetic people. While the absolute risk of CVD is greater in men than in women in that study, the opposite is observed for the relative risk of CVD, which is greater in diabetic women than in diabetic men. This graph shows this excess relative risk for women with diabetes. And interestingly, this is true at all ages of life, from the age of 40 up to 90. This higher relative risk of CVD in women with diabetes as compared to men with diabetes was previously reported by Peters and colleagues, showing in a large meta-analysis including 64 cohorts, and it was clear that there was an higher relative risk for cardiovascular mortality, coronary heart disease, and stroke. Details of that study underscore the fact that compared to non-diabetic women, those with diabetes have a much higher cardiovascular risk. This is true for coronary heart disease and for stroke as well. Women with diabetes undoubtedly lose their cardiovascular protection. And once again, there is a greater relative risk for CVD for women as compared to men in presence of diabetes. Interestingly, this meta-analysis highlights the same pattern for type 1 diabetes. That means a greater relative risk of CVD in women with type 1 diabetes as compared to men. In detail, increased relative risk for myocardial infarction, for stroke, and for CVD mortality in women as compared to men. These results suggest a role of hyperglycemia in the loss of female protection, or a role of gender-related characteristics. But how to explain this higher relative risk of CVD in women with diabetes? First, let's look at the different cardiovascular risk factors to explain the gender differences and to suggest potential underlying mechanisms. Regarding hypertension, prevalence of hypertension is more common in diabetic women after the age of 60 years. There are sex differences in the prescription and use of cardiovascular drugs, and in particular for antihypertensive treatments. It has been demonstrated that hypertension is less well controlled in women with diabetes than men with diabetes in a number of cross-sectional studies. In addition, it has been shown that women with diabetes are less likely than men to receive standard or evidence-based treatments such as ACE inhibitors or angiotensin receptor blockers. All these points may contribute to explain the greater relative risk for cardiovascular disease observed in women with diabetes as compared to men. Dyslipidemia. Dyslipidemia is more common in diabetic women after the age of 60 years. A number of studies show that women with diabetes have higher level of total and LDL cholesterol than men with diabetes. In addition, women with diabetes have higher level of HDL cholesterol as compared to men. In terms of treatment or intervention, it has been shown that women with diabetes experience a worse control of LDL cholesterol. In addition, women with diabetes are less likely than men to receive statin therapy, and women are underrepresented in a number of trials with statin therapy. Glycemia. There are some evidence based on a number of cross-sectional studies that type 2 diabetes is less well controlled in women. This may suggest less active intervention from physicians, less compliance with treatments. In addition, women are underrepresented in many trials of new anti-diabetic drugs, which raise some issue, difficulties in extrapolating benefits of these drugs to women. There are also some data suggesting increased insulin resistance in pre-diabetes or diabetic women as compared to men. For instance, in the large Australian house diab cohort, women had higher 2-hour plasma glucose levels following an oral glucose tolerance test. BMI is higher among diabetic women at diagnosis than men, as suggested by results from this large diabetes register in Scotland. This is a very important point, and it has been proposed that women have to put on more adiposity to develop diabetes than do men. Women have to undergo a greater metabolic deterioration to progress from a non-diabetic to a diabetic state. And this may explain the adverse combination of cardiometabolic risk factors observed in women with diabetes. Adverse consequences of insulin resistance appear to be amplified for women. Interesting data from the British Regional Heart Study show more adverse effect of insulin resistance in the coagulation and fibrinolytic system in women as compared to men. There was an increase in white blood cell count, increased PI1 levels, increase in the concentration of markers of endothelial dysfunction among women with diabetes as compared to men. And there was evidence for sex heterogeneity. There was a diabetes and sex interaction for these parameters. And interestingly, authors propose that the differences are explained to a large degree by the greater increase in adiposity and insulin resistance associated with diabetes in women. Regarding coagulation and fibrinolysis, there was some evidence suggesting higher levels of factor VII coagulant activity, greater concentration of PI1 in women with diabetes. A recent larger study assessed in more than 800 subjects with type 2 diabetes clot structure and show that women with diabetes had more compact fibrin clot, more resistant to fibrinolysis. This is of particular interest, suggesting the presence of a prothrombotic phenotype in women with diabetes, which may explain, at least in part, the increased relative risk of CVD in women with diabetes. Unfortunately, this point has been too little investigated. And this may suggest to prescribe more actively antiplatelet drugs and to treat more actively diabetic women. Regarding inflammation, some data suggest a similar association between CRP levels and CVD mortality for women with type 2 diabetes as compared to men. One study showed an association between CRP and coronary artery calcification in women with type 2 diabetes. And a number of studies suggest higher burden of inflammation in women with diabetes, which may contribute to explain the higher cardiovascular risk for women with diabetes. In conclusion, a combination of adverse cardiometabolic risk factors, in addition to reduced healthcare intervention, less active treatment, maybe less compliance with treatments, may contribute to explain the greater cardiovascular risk among diabetic women. In conclusion, the relative risk of CVD is higher in women with diabetes. LDL cholesterol, blood pressure are less well controlled. A large number of diabetic women accumulate a greater cardiometabolic risk burden. This highlights the fact that intensive and optimized control of risk factors is urgently needed in women with diabetes to reduce this burden.
I'd like to thank all our distinguished speakers for their excellent presentations. We have some great questions coming up, so let's get started. Now, when a woman presents with ischemia but non-obstructive coronary artery disease, let's just say she has plaques on angiogram, most cardiologists tend to be relieved and do not pursue the matter further on. And Erin beautifully pointed out that this is not a benign condition. Now, we have a question related to that. When a woman presents with INOCA, is the lipid management any different from a woman with completely normal coronary arteries?
Great. Thank you, question. I think the first part is to recognize that these women's symptoms are due to ischemic heart disease. So first of all, women are often have their symptoms dismissed. They're told it's stress or anxiety or they're having indigestion. So first of all is to have a high recognition that these women are having symptoms related to ischemic heart disease and having this high pretest probability. And I think in the past, we did these women a lot of disservice. They would have an abnormal stress test that would show ischemia, and they would have a normal coronary angiography. And then they were told that it was a false positive stress test. But now our thinking has evolved so much and realizing that non-obstructive disease is not benign and associated with major adverse cardiovascular outcomes. So in terms of management, the first thing is I try to allude to is that these are still not normal coronary arteries. And even though there's no obstruction, atherosclerosis is still a big driver of ANOCA, of ischemia with non-obstructive coronary arteries, and risk factors are still highly prevalent. So in addition to managing their angina, it's really important that these women are treated with appropriate anti-atherosclerotic treatment. So I do put them on high-intensity statins. I actually similarly try to get their LDL goals similar to obstructive disease. And I have them on aspirin and an ACE inhibitor or an angiotensin receptor blocker. We have less data in this area, but there's certainly good reasonable extrapolation that these would work, in the setting of atherosclerosis. And then additionally, of course, they need therapy for their angina if they're having symptoms related to their quality of life. So I would really encourage cardiac rehab. So exercise and physical activity, helps all patients with angina, including ANOCA. But of course, then you have your usual angina treatments, your beta blockers, your calcium channel blockers, like amlodipine, long-acting nitrates. So although I do find a lot of women who run with lower blood pressures don't tend to tolerate high doses of nitrates. They tend to have a lot of headaches. So I've run into some barriers with that. Ranolazine seems to work in a lot of these patients who have microvascular angina. So I think that's certainly an option. And then additionally, there's other therapies that, have been looked at with variable success, like tricyclic antidepressants and L-arginine. But making sure patients are on those standard of care first, their anti-atherosclerotic regimen, and then their anti-anginal regimen. But the biggest hurdle is many of these women are not even told that they're, at increased risk, that their symptoms are ignored or dismissed.
Great. Janine, we have a question for you about Lp(a) after menopause, because there are some studies saying in some women it may go up, but some say it stays the same. It's genetically determined anyway. So what do you say? You're mute. Okay.
Yes, well, thank you very much. And concerning Lp(a), yes, there are studies that more than one that say that Lp(a) increases after menopause, but it's not sure if that's really age-related or if it's menopause-related. And the SWAN study, that's the study I discussed in my presentation. And they really wanted to, well, divide like what's menopause and what's age-related. And what they found there is that Lp(a) indeed, as insulin resistance and blood pressure increased with age, but not particularly with menopause. Interestingly is that, well, we know that Lp(a) is very difficult to treat the levels, but hormone replacement therapy is one of the few therapies that really can decrease Lp(a) levels. However, it's never tested for that purpose.
Right. Any other comments on this, or should we move to the next question? Okay. Now, we have a lot of questions about non-LDL. We know that LDL is not the whole story, and in the European guidelines, we have secondary goals of non-HDL cholesterol. There are some questions about the LDL-HDL ratios, the protective effects of HDL. So I would like to hear all of your comments on that, starting with maybe Fabrice. Is HDL protective in all? Because we know from the Copenhagen and other studies that there is now a U-shaped relationship between HDL and cardiovascular disease and even mortality. So what do you think? Fabrice first, then Erin, then Janine, please.
Hello. Yes, the relationship between non-HDL and cardiovascular risk is also true for type 2 diabetic women as well. So I think, yes, it is a parameter of interest as it is integrated in the cardiometabolic profile of insulin resistance women. So yes, it is of interest to look at that, but it's only part of this cardiometabolic profile. So nothing else, especially for type 2 diabetes, but most of them have a low HDL cholesterol level, lower than non-diabetic women, but it's what we observe in clinical practice.
So, as you mentioned, that there's a U-shaped relationship with HDL with both low and high levels at risk. And I find that a lot of women are falsely reassured. I have a whole bunch of women in my clinic that have terrible coronary disease, and they have these HDLs of 90, 100, 110, and they were told that they were fine. They didn't have to worry anything. Like, you're lucky. Your HDL is 120. You're lucky. And they actually have terrible coronary disease. And I think it was a missed opportunity, because I think what's happening on these really high spectrum is that this is dysfunctional HDL, this big fluffy HDL that's not effective at reverse cholesterol transport. And maybe your more optimal HDL is more around level of 50. So I don't really find a lot of reassurance to patients who have these very high HDLs, but I do pay attention to triglycerides. So there's lots of data from both genetic and interventional and observational studies that suggest that triglycerides-rich lipoproteins are causally related to ASCVD, and that even on statin-treated patients whose LDLs are achieved at goal, elevated triglycerides is still a marker, an independent marker of future ASCVD risk. And so after the REDUCE-IT trial, looking at icosapent ethyl in statin-treated individuals who have ASCVD or diabetes with a major risk factor, we see a 25% reduction in MACE. So I am using, once I have patients on statins, if they have elevated triglycerides in these high-risk groups, icosapent ethyl, which is high-dose purified EPA, as a secondary treatment target.
To avoid a false sense of security, in the most recent European guidelines, we removed the ratio because, as you said, physicians were feeling that way. But now we have non-HDL as a secondary goal, which captures the risk caused by remnant lipoproteins. Janine, do you want to add something?
Yeah, well, I think that's just to mention that what we measure in the clinic is HDL cholesterol. And HDL cholesterol is not really capturing well HDL function. And I see that Marina Kugel is also online, and she also published a New England paper showing that it's all about HDL function. So it's cholesterol transport capacity, but also maybe the proteomic capacity of HDL. HDL has more than 90 different proteomes on it, and it might also be that the one HDL is not the same as the other one. So HDL is much more complex than LDL, and that's why HDL cholesterol levels do not say so much.
I fully agree. There are questions about statin-related adverse effects being more frequently in women and what we can do about it. Any comments on that?
Yes, I mean, certainly statin-associated muscle symptoms are more common in women, and that's one of the reasons why there's higher discontinuation. But the question that we all struggle with is how much is real versus the nocebo effect. So certainly there's been several studies like the Samson and a one study of patients with statin-associated muscle symptoms that, compared to themselves as control, it's estimated about 90% of statin-associated muscle symptoms are due to the nocebo effect. They're elicited by placebo too, and that patients do experience symptoms, but the symptoms are more from the act of taking a pill rather than what's in them. And in the Samson trial, once confronted with this, about 50% of patients were able to restart their statins. So I think it's really important that women who are high enough risk are appropriately treated, that we should do a re-challenge. The vast majority of patients, including women who are re-challenged on a statin, are able to tolerate it. You can start low, low dose every other day. Sometimes we have better luck with like rosuvastatin and pravastatin with muscle aches. But then high-risk secondary prevention, I'm excited now that we have more options. If we really can't maximize statins, we have ezetimibe, we have PCSK9 inhibitors. I'm very excited about inclisiran. And so we have more options than we did before to try to achieve that LDL targets.
Yeah, maybe I can add to Erin that it's what's very interesting in this matter is sex versus gender. Because we know that gender is more like the cultural ways how women behave compared to men. And we know that women, for example, they read the labels, which are included in the medication. And also the last study that I showed, I thought it was so interesting because every time we say women have more side effects, well, on the other hand, I have so many men who have side effects on statin, but it's also a cultural thing that it's more accepted from women to discuss their side effects than for men who have to be tough and don't have side effects. So in the case of statins, it's always puzzling me, like, is it really sex related, which you can think of because women are smaller and they have pharmacodynamics is different than men. But I think that gender also really plays a role here.
A question for Fabrice, and we discuss this all the time. Now, should a woman with an acute coronary syndrome plus diabetes, meaning that she's at very high risk of having a recurrent event, should be treated upfront with statin and ezetimibe? Because in the guidelines, we have to rely on randomized trials, and we recommend first statin. If they're not at goal at 4 to 6 weeks, we add ezetimibe. So what do you think about upfront combination to get the LDL down right away in these patients?
Yes, I agree. I think that this woman should be treated aggressively or intensively. It's certainly very important. And yes, I know that the guidelines now introduce a little distinction, but I think we should be more aggressive in treating this woman who are at a very high risk in the long term.
Okay.
And
Janine,
especially if triglyceride is increased, just to add this point. But it's
let's get to first LDL goal, then non-HDL goal, if you can, to prevent as much residual risk as you can. Janine, about polycystic ovary syndrome, what happens to lipids then? And also, are there any statin-related side effects in the placenta in a pregnant woman? 2 questions for you.
Wow, interesting questions. Yeah, well, regarding PCOS, those women have a more unfavorable lipid profile compared to women who do not have PCOS. So they have higher LDL, but especially they have lower HDL and higher triglycerides. However, PCOS is a syndrome, and it's not like one disease because you have different criteria. So, well, you can wonder, is it really women with PCOS have more obesity? So is it really the obesity, or is it the higher androgens that they have that is causing the more adverse lipid profile? Well, so we don't know exactly, but in generally, we know that women with PCOS have a more unfavorable lipid profile. However, what's interesting is that what we recently also found is that although they have more risk factors, they do not seem to have an increased cardiovascular disease risk. Probably because they have a later age of menopause, and also because they have an increased level of estrogens, which is stable during their whole life because they have less menstrual fluctuations. So maybe the one hand, well, the more risk factors is counterbalanced by other factors.
Mm-hmm.
And regarding this, oh yeah, sorry, please add anything.
I was just going to say there is some differences across studies. So there are some studies that have shown PCOS is independently associated with CVD, even after you adjust for risk factors, but not all. And likely it's because there's so much heterogeneity about PCOS. It seems like the hyperandrogen type. And there also seemed to be an age. It seemed like in older women, a history of PCOS didn't seem to confer a risk anymore if they were able to survive to an older age. But in the younger age, under 55, the history of PCOS was associated with increased risk. So I do think there is some differences across studies.
Yeah, but it probably also has to do with the type of PCOS because, well, you have so many different phenotypes and they're all called PCOS. And so it's very difficult to say like it's PCOS or if it's a specific like a hyperandrogen type of PCOS that confers the most risk. And then about the placenta, well, very interesting is that we as physicians, we always say stop the statins before you become pregnant and only restart after breastfeeding. And then in the op-gene field, there are whole loads of studies now, small studies, and that is in women who have preeclampsia, and they're actually treating those women with statins. And there's even a meta-analysis of those studies already. So, and I just looked it up about placenta and what the effect is of statins. And what I found is that there's a reduction in S-FLT secretion, and that's the main driver of blood pressure, so that's okay. And there's also, statins can increase ENOS in the placenta, which is also okay. But also increase of soluble endoglin, and that's an anti-angiogenic biomarker, and so that's not okay. So, but there's a lot of things happening in the placenta caused by statins. So it's a very interesting, and I think right now still a moving field, and we will hear more about that in the future.
Okay. There's a question whether there are specific markers that are increased in women in terms of cardiovascular risk prediction.
Well, certainly women have higher BNP levels. That's been shown in stable asymptomatic cohorts. So women have higher BNP than men. But the markers do seem to predict equally. Both troponin, high sensitivity troponin, and BNP seem to have similar prognostic risk prediction.
Maybe we consider it's not a marker, but an imaging marker. Calcium score increase confers a greater risk in women compared to men, because usually women do not have as much atherosclerotic burden. There is a question about giving intravenous or external HDL to decrease risk, and that has been tested a while ago. Have we given up on it altogether, Fabrice, or are there any studies going on about giving HDL externally, functional HDL, to decrease cardiovascular risk?
I'm not so specialized in this, so maybe I let my colleagues answering.
Nothing big going on as far as I know. Janine, Erin?
No, I mean, most of the studies I've been focused on more LDL lowering therapeutics, and then there's a lot about triglyceride-rich lipoproteins and remnants, with ApoC3 inhibitors and ANGPTL3 inhibitors. So I think there's a lot more trials going on for those therapeutics as opposed to HDL.
And Lp(a) also.
Oh yes. Oh yes.
Yeah. Which will be very interesting.
That is going to be conquered soon, we hope.
Yes, I'm looking forward to that one.
And one final maybe question asking about the studies investigating the reasons why providers may not offer statins to women and why women refuse them compared to men. Janine, do you want to comment? You already alluded to that briefly.
Yeah, and I still think that the interaction between a healthcare provider and a patient is crucial. And it would be also very interesting to see, who is the healthcare provider, who is prescribing statins or not statins. Are that men or are that women, and why are they doing that? On the other hand, there's also what we discussed before. Women have ideas about statins that they're not good for them, and also that was surveyed in the study I discussed. I think that it's our responsibility as healthcare providers to also reassure women and to say, they are working in women, and there is really very much data about statins that they are safe in women. So that we can convince women that it's a safe therapy and that it's very effective for them.
I'm very happy to have Marina Kushel among us, and she has informed us that a phase 3 trial with a recombinant HDL is ongoing. So we'd love to hear the results of that.
Great.
I think we have covered most of the questions. We have a journalist among us asking whether this will be a press release. Never thought of that, but we can write about it on our website. Yeah. Good to hear. So we will write a report on it on our website together with Janine for people who are interested in having that. And of course, the video will be available on the EAS website for those who missed it. So this has been a very nice afternoon. Thanks to our distinguished speakers and all of you attending. Thank you so much for attending. And I'd like to invite all of you to the European Atherosclerosis Society Congress, which is happening at the end of May. It was supposed to be in Helsinki, but now it's going to be fully online. And we will discuss more of these issues in detail and some basic science as well during our Congress. So please join us for our Congress. Thank you very much. I hope you have a great rest of the evening. And stay safe, please.
Thank you, Lale, for hosting.
Thank you.
Thank you.
It's a pleasure.
Peter, are we connected?
Yes, we are still online, so you can just shut down your cameras.
Okay, and we should talk about this, Janine, among ourselves, and Erin as well, about writing a very brief report on it we'll do most of the work and send it to you for your approval, Erin.
That sounds great. And I'm anxious to look up that HDL trial. I wasn't aware of that one.